fresh knowledge of this for the SCA and going through this website again. Let's carry on from adult psoriasis management algorithm. So the adults psoriasis topical treatment pathway. It's from Lancashire NHS. Emollients should be applied generously to reduce fall of scales at all steps in therapy and for all body areas, excluding scalp. So lots and lots and lots of emollients, very important. Trunk and limb psoriasis involvement, so it could be trunk and limb, face, flexure, genitals, scalp. Always know that genitals, the skin in the genitals are very sensitive, very fine skin, thin skin. So you need to be very careful with topical steroids. So trunk and limbs, once daily potent corticosteroid, potent betamethasone, and once daily vitamin D. So you can see that it's potent. This is not clobetasol, this is not Umovate, this is potent corticosteroid, Betamethasone plus once daily vitamin D preparation. Apply at separate times of the day. The betamethasone, calcipotriol, there's a combination. Or you can use betamethasone, which is Betamethasone in the morning, calcipotriol at night, so apply at separate times per day. We do the patient at 4 weeks. Discontinue if ineffective after maximum of 8 weeks. Now, if ineffective, you jump down there, you use potent corticosteroid. Clinicians have the option to fast track to step 4 if there's specific clinical benefits. So you can always move from there and fast track down. So potent corticosteroid plus vitamin D combination preparation once daily for 4 weeks, which is now a combination of betamethasone, calcipotriol in 1, 2-in-1, and topical cream. Now discontinue if ineffective after maximum 4 weeks treatment. And then you can always refer patients with psoriasis is not controlled to the specialist dermatologist service. And what do we typically do there is the PUVA, the phototherapy like PUVA or UVB treatment. I want to go stepwise. You can always move vitamin D preparation like calcipotriol once a day, or calcipotriol. So it was once a day. We can then discontinue the steroid and use the vitamin D only. So calcipotriol twice daily, or calcitol once daily. Discontinue if ineffective for that 12 weeks of treatment. If the vitamin D analog alone doesn't help, then we can reintroduce our potent corticosteroid twice daily for 4 weeks without the vitamin D. So essentially, you use vitamin D and steroid initially, it doesn't work. You move to vitamin D only, doesn't work. You move to steroid only. So you're just trying, playing around the same thing, the same medications, isn't it? But trying to see how you can have certain breaks. So here isn't you're having if you use 8 weeks, have your 4 weeks of steroid break usually. Even though you can use for 3 months of vitamin D alone, it doesn't help you introduce your potent corticosteroid betamethasone or fluocinolone twice daily for 4 weeks, or use a quota containing preparation once daily for 4 weeks. Discontinue the patient cannot tolerate or once daily is preferred to improve adherence. You can always go to try this for 4 weeks, then you can refer to dermatology. And it's actually very similar, most likely. I'm not sure, maybe genital psoriasis could. So they might want to bring in a little bit more complexity in the SCA. So they might say, okay, genital psoriasis, in which case we need to use a very mild potency, topical steroid hydrocortisone. So once or twice daily, mild or moderate corticosteroid, so clobetasone or hydrocortisone, off-label use applied for maximum of 2 weeks. Discontinue if unsatisfactory response or continuous treatment requires to maintain control. Calcineurin inhibitor like tacrolimus or pimecrolimus or calcineurin inhibitor twice daily off-label use for up to 4 weeks. I don't think I'll be confident in prescribing this tacrolimus cream I already want to refer to dermatologists, so seek get advice from dermatologists in their way of advice and guidance. To be initiated on the advice of a clinician with expertise in psoriasis, exactly, e.g., a GP with special interests, yeah, or a dermatologist. Continue to review for improvements as directed. And special interest is quite vague. A GP with special interests doesn't just mean you have interests in something, but you should have gained an extra experience or knowledge and experience in that area. So if I have a question in psoriasis, if it's vulval psoriasis, I would like to start with hydrocortisone, obviously, but you could always use Umofate as well. What's just 2 weeks, not long. Scalp psoriasis, scalp is a thick skin, so one daily potent corticosteroids, so betamethasone for up to 4 weeks. Discontinue if ineffective after maximum of 4 weeks. Consider using a formulation of potent corticosteroid and a topical agent to remove adherent scales. So betamethasone mousse or betamethasone and salicylic acid, very important. Discontinue if ineffective after maximum of 4 weeks treatment. Now, potent corticosteroid or plus vitamin D combination preparation like betamethasone as well once daily for 4 weeks, or vitamin D only. So you can see here that they're starting with potent steroid alone. In trunk and limb, you can start with potent steroid and vitamin D analog, but then further down the line is scalp psoriasis, you then introduce the vitamin D analogs like calcipotriol. There's not helping vitamin D only preparation for those that cannot tolerate further causes of steroid with mild or moderate psoriasis for 8 weeks. Discontinue if ineffective after maximum specified interval, usually will be around 12 weeks, which is 3 months. Twice, if that doesn't help, you can step up, can move, progress down the algorithm twice daily, very potent corticosteroid for 2 weeks. Once or twice daily coulter preparation, coulter lotion, coulter salicylic acid ointment for 4 weeks. Discontinuation effective, obviously, if you're not referring to dermatology, we then make considering phototherapy like Priva, EVP treatments. Aim for a break of 4 weeks between courses of treatment with potent or very potent corticosteroids. Consider topical treatments that are not steroid based to maintain psoriasis disease control during this period. So when you're having your steroid break, typically you want to place a patient on ongoing vitamin D analog treatments, calcipotriol, or Volta. Treatment should only be initiated in primary care if the patient does not fall within the criteria for referral to specialist dermatology service. So usually, typically, if the patient has more than 10% of body surface area involvement, you want to be referring straight to dermatology. Dithranol could be considered as an alternative to coulter preparation at this stage of therapy. Where is that? Somewhere. That's there. Very smoothie. So coulter, you can also use ditronol. So psoriasis treatment in children, let's see how that differs from the adult treatment. For children and young people with psoriasis topical treatment pathway, please note, make referral as initial presentation of children and young people with any type of psoriasis to a dermatologist. So even before you start this treatment, make a referral. Emollients should be applied regularly to reduce fall of scales at all steps in therapy and for all body areas, excluding scalp. So trunk and limbs, face flexure genital scalp. So trunk and limb. So a child's age more than 1 year up to 6 years of age, once daily, potent corticosteroid. Review at 2 weeks, discontinuation effective. So using potent corticosteroids like that benefits in a child. You have to be very careful with that. Prepare for that treatment until advised by specialist dermatology service. So you can see you try the potent steroid for 2 to 4 weeks, but you don't just want to continue because it's a really young child. When you seek dermatology in it. The child is more over 6 years of age, once daily vitamin D calcipotriol for 2 weeks, discontinue if ineffective after maximum of 5 weeks. Now, face flexures, genitals, softer skin, once on age more than 1 year, once between daily mild or moderate corticosteroid, clobetasol or hydrocortisone for maximum of 2 weeks, discontinue if unsatisfactory response or continuous treatment required to maintain control. Now, for scalp psoriasis, the child is over a year. once daily potent corticosteroid like betamethasone fluoxetine for its continuation effective after 1 or 4 weeks. If age, you must get advice. If age more than 6 years, consider using different formulation of potent corticosteroid and or topical agents to remove adherent skin. So betamethasone moves unlicensed for using those less than 6 years. Up to 2 weeks of betamethasone and salicylic acid. Salicylic acid helps to um, reduce the thickness of the scalp so institution. Let's proceed. Well score for DVT. So just for us to look at familiarize ourselves with the parameters. So the well score is less useful in hospitalized patients, obviously. There are a few versions of these criteria with minor differences based on the study. So things you need to be looking out for: active cancer treatment. The patient has on treatment for cancer or palliation within 6 months. That's something you need to be checking. The patient has been bedridden for more than 3 days or major surgery within the last 12 weeks, within the last 3 months. So it's significant. If there's a calf swelling more than 3 centimeters compared to the already long leg. So collateral, non-varicose superficial veins, entire leg swollen, localized tenderness along the vein system, pitting edema confined to symptomatic clinic. There's paralysis, or recent cluster immobilization of the lower extremity. Previously documented DVT, alternative diagnosis DVT likely in ones too. Previously documented DVT plus one, paralysis, or recent cluster immobilization plus one. Pitting edema plus one, plus one. Just to familiarize with things that need to be. The patient comes and says, "Oh, doctor, just woke up with the pain in my right leg." You want to questions need to check for any past medical history, any um, recent immobilization or reduced movement, redundancy, any swelling, pitting edema, redness, pain, hotness, they feel hot, they feel unwell. Of course, you need to be checking red flags for PE, and if you any chest pain, shortness of breath, things like that. There's just pretty deeply critic, so it's just asking those kind of red flag questions as well. When it comes to well score for pulmonary embolism, just look at the criteria: clinical signs and symptoms of DVT plus 3, Ps number one, likely diagnosis plus 3, heart rate of more than 100, so tachycardia, immobilization for at least 3 days of surgery within the last 4 weeks. So previous objectively diagnosed PE or DVT, previous DVT or PE, hemoptysis, malignancy with treatment within 6 months of palliative. So similar, some overlap with the risk factors for DVT because in terms of its current system. So we're thinking so palpitations and tachycardia, which could present in palpitations. Low risk. You have a score of 4 or more, then there's a high risk of DE. And let's look at some 2-week referral criteria. So now it recommends referral for suspected bowel cancer based on the following criteria. So colorectal cancer, if the patient is aged under 50, with rectal bleeding, and any of the following unexplained symptoms or sign or findings: abdominal pain, change in bowel habits, weight loss, iron deficiency, anemia. So less than 50, rectal bleeding has weight loss. Of course, you have to be to equate abdominal pain. Age 40 and over with unexplained weight loss and abdominal pain. Age 50 and over, unexplained rectal bleeding. Age 50, age 60 and over with either iron deficiency, anemia, or change in bowel habits. Rectal or abdominal mass not pelvic. They consider patients with low risk symptoms of testing positive for FIT10. So patient with low risk symptoms or having positive Q-FIT, which is blood in stool. All patients with suspected colorectal cancer, including those with rectal bleeding, should have a fecal immunochemical test completed prior to referral. So, even if you're going to do a 2-week wait, you need to do a Q-FIT, how they're saying, prior to referral. For anal cancer, unexplained and anal mass or unexplained anal ulcerations will refer without need for FIT test. The patient is having a fissure in anal or no anal ulceration. It is a fissure in anal. It's not healing. Obviously, you want to refer to the surgeons. But if you're noticing funny looking anal fissure, it's just a malignant fissure, usually not be a linear fissure. Not just be a fissure, to be like a proper ulcer, in our area. But it's malignant, obviously. It's a destructive lesion. Now looking at Q-FIT. Overview of referral pathways based on symptoms and Q-FIT results. Symptomatic patients do not be reassured by any recent negative screening Q-FIT results. So if the patient is symptomatic, don't be reassured by the fact that they had a negative Q-FIT in the last 6 months or something. These patients need clinical assessment and repeats of the Q-FIT. High risk symptoms, risk of cancer. Let's skip that. So we will refer for suspected breast cancer. So referral criteria: suspected breast cancer referral. The patient is age 30 or over with unexplained breast lump with or without pain. Need to do 2 week referral to the breast service to without a breast cancer. Patient is age 50 or over with any of the following symptoms in one nipple. Any of the following symptoms in one nipple. So it's age 30 over with unexplained breast lump. Okay, so you're not thinking it's a fibroid adenoma. You don't think it's a breast mass, right? You think it's something more sinister. So obviously, age 50 or the following, it's any of the following symptoms in one nipple only. So there's a nipple discharge, unilateral nipple discharge, unilateral nipple retraction, unilateral skin changes of concern. For example, males over 50 unilateral firm subarachnoid mass with or without nipple distortion or skin changes. And you can check now to make sure there's nothing there. There's nothing. Thankfully, to consider suspected cancer referral. Age over 30, unexplained lump in the axilla and have skin changes that suggest breast cancer. I wouldn't even say consider. I would be definitely doing a suspected cancer referral, not just to referral, to the breast service. You have an unexplained lump in the axilla. Depends on how the lump heals. You were thinking, okay, could this be a lymphoma or is it coming from the breast, right? It's a lymph node, is a lymphoma, is it coming from the breast? Well, here then I say person has skin changes that suggests breast cancer, obviously it's immediately. A non-urgent referral should be considered in patients who are under 30 with an unexplained breast lump. So because it's more likely to be a fibroadenoma. Women aged younger than the fibroadenoma could be traumatic factor necrosis if they've had trauma to the breast. Women aged younger than 30 with a lump, so you could do a non-urgent referral, and they could be seen within how long? Within 68 weeks. You should be seen within 68 weeks, maybe longer. Patients with breast pain and no palpable abnormality when initial treatment fails and or with unexplained persistent symptoms. This mammography in these patients is not recommended. So 2-way referral criteria for suspected lung cancer. So referral criteria: lung cancer or mesothelioma. So the patient has chest X-ray findings that suggest lung cancer or mesothelioma, and it's with referral. Chest X-ray should be no more than 3 weeks old. Okay. So, an urgent chest X-ray, recent chest X-ray. If the patient is aged 40 and over with unexplained hemolysis, please arrange the chest X-ray to take place within the next 48 hours. For my minor or resolved hemoptysis without other symptoms such as lung cancer, consider just a chest X-ray. So minor, like person says, oh yeah, I coughed and there were just some blood stains in my spit, in my phlegm. Then you're like, okay, fine, and it's not, you know what I mean? It's not like a severe hemoptysis. You want to do a chest X-ray first. Obviously, the patient is having things, symptoms like weight loss, the patient is a smoker, and those are factors that increase your likelihood or your suspicion of a lung cancer. Then you might need to be thinking of something, of course, an urgent chest X-ray. Um, if the patient has a normal chest X-ray but has a high index of suspicion of a lung cancer, should do need to week with explaining that. So yeah, this person had negative, but this is coughing, has been coughing for the last 8 weeks. Is a smoker, and probably has some hemoptysis, some chest pain, things like some weight loss. Yeah, 2 week wait straight up. The following recent bloods less than 8. The following recent bloods less than 8 weeks old should be extremely helpful for can EGFR, clotting UNEs, AFT bone profile. To the referral criteria for suspected melanoma, because melanoma is quite a common malignancy. Malignant melanoma or simply melanoma. So if the endoscopy suggests melanoma of the skin, suspicious pigmented skin lesion with a weighted 7-point score of 3 or more. Pigmented or non-pigmented skin lesion that suggests nodular melanoma, e.g. bleeding or vascular nodule, unless definite benign parameters. NICE referral guidelines on lesions suspicious of malignant melanoma, patient with a score of 3 or more, as follows major features scoring to each one: change in size, and most importantly, change in size, change in color, change in shape. Okay, irregular shape, irregular color. Those are the 3 things that you need to be looking out for in any more changing, increase in size. So size, color, and shape, irregular shape, margins. Now, other things that are important as well, changing sensation, oozing, inflammation, larger than the 7 millimeter more. But the most important things are these ones. Referral criteria for suspected hematological cancer. So acute leukemia. If your blood film suggests an acute leukemic leukemia field, please arrange an immediate admission with a hematologist. Myeloma. If results of protein electrophoresis or induced protein suggests myeloma, you need to do 2 week with hematology. Radiology reports reported as suggestive of myeloma screen confirms myeloma, 2 week with hematologist. When considering referral, take into account other features including hypercalcemia, abnormal full blood count, and kidney injury. A myeloma screen includes full blood counts, renal function, calcium, protein, electrophoresis, radioligand tumors. Myeloma is unlikely with an IgG below 15, IgA below 10 in the absence of other symptoms. In which case, consider a routine referral. Spinal cord compression or acute kidney injury suspected of being caused by myeloma should be discussed more urgently with on-call hematologists. A polyclonal diffuse increase in gamma globulin is not associated with hematological malignancy. So a polyclonal increase in like raised IgE, raised IgA, you're like, okay, it's unlikely because most times in hematological malignancies, like in myeloma, it's usually monoclonal gammopathy most times. It's usually one that is simply IgG or IgA. These are not Hodgkin's lymphoma, unexplained lymphadenopathy. Unexplained lymphadenopathy is defined as more than 1 centimeter and persisting for 6 weeks. There's unexplained palpable splenomegaly, unexplained radiological splenomegaly, but plus symptoms or signs. When considering referral, take into account any associated symptoms, particularly unexplained hair and fever, wrenching eyes, force with or without weight loss, shortness of breath, pruritus, or alcohol-induced lymph node pain. Important alcohol-induced lymph node pain. Everybody has a lymph node that's they drink alcohol when they have some alcohol. What happens? Lymph nodes of lumps gets painful. Please attach the recent pathology results if available. Chronic CLL is not an indication for 2 week referral. Chronic lymphoid leukemia because it's a smoldering malignancy. It's not there. it's not a malignancy that kills you so fast. So it's not an you do a less a non-urgent referral to hematology when the blood films are just yellow. So you referral criteria for suspected gynecological cancer. So referral criteria, suspected gynecological cancer referral criteria. So ovarian cancer, including CA125. Physical examination. So if physical examination identifies ascites or a pelvic or abdominal mass, which is not obviously fibroid, you should be doing a 2-week referral to gynecology. What some people typically do, if you feel a mass, we'll go to 2-week wait. If you don't feel a mass, patient has ascites, you need to do a 2-week wait. Actually, there's no point waiting for an ultrasound. Endometrial cancer, refer patients age 5 and over with postmenopausal bleeding, so which is unexplained vaginal bleed of more than 12 times after menstruation stop because of menopause. Consider referral if age under 55 with postmenopausal bleeding. If patient is on HRT, use it for 6 weeks to evaluate bleeding. May be helpful when considering referral. Please provide BMI, height, and weight, postmenopausal, past medical history, blood pressure, allergies, personal medications, or cervical cancer. When the appearance of the cervix is always considered cervical cancer, and you refer, you have a normal looking cervix, and the patient does have, their last smear was normal, then you shouldn't be thinking of cervical cancer. Vulvar cancer, unexplained vulvar, lung, or secretion of bleeding, vaginal cancer, unexplained papillary mass in or at the entrance of the vagina. Recent vulvar counts will be healthy to make sure they're not anemic, etc. And to make sure, majorly anemia. And sometimes thrombocytosis could also indicate malignancy, possible malignancy. So we will refer criteria to neurology service. Refer patient urgently with symptoms related to the CNS, including progressive neurological deficits, new onset seizures, headaches, mental changes, cranial nerve palsy, intellectual sensor neural deafness, universal sensory neural deafness in whom brain tumor is suspected. They're thinking maybe this person could have an acoustic neuroma or a neurolemoma, so you might need to be doing a 2-week basic referral to neurology. Headaches of recent onset accompanied by features suggestive of sensory neural hearing loss. You naturally, it's actually 2-week wait to ENT exams. Headaches of recent onset accompanied by features suggestive of this intracranial impression. For example, vomiting, drowsiness, posture-related headache, pulse synchronous tinnitus, or other focal or non-focal neurological symptoms, for example, blackouts, changing personality or memory. A new, qualitatively different, unexplained headache that becomes progressively severe. Suspected recent onset seizures, referred to neurologist. Consider urgent referral to an specialist in patients with rapid progression of subacute focal neurology, unexplained cognitive impairment, behavioral disturbance, slowness, personality changes confirmed by a witness, and for which there is no reasonable explanation, the absence of other symptoms and signs of brain tumor. Consider non-urgent referral or discussion with specialists for unexplained headaches of recent onset. Recent for at least 1 month. Not accompanied. So, for instance, you're seeing a patient who is 70 years old having headache, and the specialist tell you that they've previously not been in the kind of headache kind of people who they've not suffered with tension headache or migraine in the past, no recent stresses, and we're wondering, this patient is having this disturbing headache, on one side of the head. Even if they don't have neurological deficits, you're quite worried. And this is not a person that is typically known to have headaches. So could they have the ability to brain tumor, for instance? Or to be thinking of a non-urgent referral anyway, or discussion. Refer urgently. Patients previously diagnosed with any cancer who developing of the following symptoms: recent onset seizures, progressive neurological deficits, persistent headaches. So even if a person has had breast cancer in the past 5 years, 10 years ago had breast cancer and having this new onset headache, recent onset, persisting headache, you want to be thinking, could they have had a recurrence brain metastasis, for instance, new mental or cognitive changes, and new neurological signs. For ankle pain, following trauma, want to know, okay, their likelihood of ankle fracture, age 55 or more, isolated tenderness of the patella, isolated tenderness of the patella, the tenderness of the fibula head. The patient is unable to flex the knee to 90 degree, following trauma, I think, could there be fracture? Should I be X-raying this knee? Patient is unable to weight bear, both independently and in the ED. Patient is able to take 4 steps. A patient is able to take like 4 steps, so you only use considering getting an extra knee. The same thing goes for the ankle, upper ankle, pain persistent in the malleolar zone, ankle area, X-ray. There's bony tenderness in the posterior edge of the lateral malleolus, bony tenderness posterior edge of top or the medial malleolus, inability to weight bear both immediately after the injury and in ED, or in your case, obviously, in your GP practice, patient is unable to weight bear foot area, and bony tenderness at the base of the fifth metatarsal, bony tenderness and inability. So essentially, there's bony tenderness. You need to be considering the possibility of a fracture following, you know what I mean, bony tenderness following. It's really the patient is not able to weight bear. Or extremely painful unattempted weight bearing, like there could be metatarsal fracture, or the fracture of the collarbone, Achilles, or whatever. Let's keep this head and neck, head injury. Okay. So primary and secondary fracture prevention. Let's see if we look at that. Should we look at that now? Yes, let's do that. So essentially, osteoporosis assessments, so pathway from risk factors to pharmacological treatment, selection, postmenopausal women, we have primary fracture prevention, secondary fracture. So primary fracture prevention means the patient hasn't had a fracture. You want to prevent them from having fracture. Secondary fracture means they've had a fracture. You want to prevent them from having a repeat fracture or further fractures. Let's look at primary fracture prevention. Clinical risk factors. Age 50 or more. Very strong clinical risk factor. Patient less than 50. The factor risk assessment will be a FRAX score. The FRAX score is the 10-year risk is 10% or more from FRAX score. 10% or more, then you go here to the DEXA scan. And then the DEXA scan will show you either it's normal, so the T score is greater than -1.0, so normal. The T score is between -1.0 and -2.5. If it's osteopenia, the T score is less than -2.5, which means if the T score is greater than -2.5, it's greater than 2.5 on the negative side. You know what I mean? So that's osteoporosis. Because the interpretation is you're thinking backwards, so it's thinking towards the negative in terms of how thin the bone could be and might be. Now, if your FRAX score is less than 10%, you advise lifestyle advice, reassess if risk profile changes. Now let's look at for a patient who has had an osteoporotic fracture. The person has had a hip fracture. This person is suitable for oral therapy. If yes, do a DEXA scan and then check. If no, DEXA scan. Zoledronic acid annually. And then give the infusions and if you have to find it. Or here you can go to DEXA scan. So if the person has osteoporosis, or severe osteoporosis, fine. If yes, high risk of hip or non-vertebral fracture. So you just check in, want to know, should I do DEXA scan? So the FRAX score is high, more than 10, you do DEXA, then DEXA will confirm with one osteoporosis opinion, but then now decide if you want to be treated or not. Person has already had an osteoporotic fracture. Usually we just counsel them on the need to actually start bisphosphonate in addition to calcium and vitamin D treatment. So this is what the FRAX score. FRAX score operates in this osteoporosis and fragility fractures. The FRAX score means fracture risk assessment to FRAX. So typical questions that are used to weight your fracture risk. Your age, your sex, male or female, your BMI, so weight and height. If you had previous fractures, obviously. Parents fractured hip. So that's not family history. So previous fracture could be wrist fracture, for instance, or spine. Parents fractured hip means your parents, your original hip. So imagine maybe your original hip fractured, yes, on current smoking. Or does it mean family history of fracture, like your parents? I'm getting confused that parent fractures hip. Current smoking, so smoking status, patient on glucocorticoids, yes or no? Has person involved matter arthritis, yes or no? Secondary osteoporosis, yes or no? Alcohol of 3 or more units per day, which is gonna be more than 21 units a week. 3 or more units a day. So, and then femoral neck, bone mineral density, if you have that. At the time, we won't have that, so we use the clinical review. And then we'll calculate without bone mineral density. This one says, yeah. So we'll calculate the FRAX score. So this one is the FRAX score for hip fracture. The risk of hip fracture is 10%, and the risk of major osteoporosis is 25%. And then after that, you take your, so that you would go into your NOG interpretation FRAX scoring. You go into the NOG. This patient is same 25 for major osteoporosis. If you look at that, hip fracture 10. Then you come into your NOG. The NOG plots where the patient either give lifestyle advice or measure bone mineral density, which is using the DEXA scan, or if you even be treating straight up some cheap plates. Muscular special evaluation. So depending on intervention threshold is here. So this patient's score is right there. So let's look at interpretation of FRAX. Following assessment of fracture risk using the FRAX score in the absence of bone mineral density, the patient may be classified to be low, intermediate, high, or very high risk, where both the major osteoporosis fracture and hip fracture probabilities fall below the treatment threshold. Lifestyle advice should be given, and a further assessment is recommended in 5 years or less, depending on clinical context. New clinical risk factors develop where fragility fracture occurs. Obviously, when you know that means basically myalgia, rheumatic, and the patient needs to be on long-term steroid. Obviously, their risk has changed, so you need to stratify their risk. Now, low risk, okay, so intermediate risk. So low risk, give lifestyle advice. We assess in 5 years or less, depending on clinical context. Intermediate risk, measure bone mineral density and recalculate fracture risk. If bone mineral density measure and it's not practically frailty or is unavailable, offer treatment if risk is at or above the intervention threshold. For high risk, offer treatment to reduce fracture risk. Make sure you still have to, when at this point where you're going to start treatment with this phosphonate calcium vitamin D, you need to still get a bone mineral density DEXA scan to guide medication choice and provide a baseline for bone mineral density monitoring. Exactly. You want to, of course, confirm radiologically, and then when you repeat your DEXA scan in 5 years' time, you want to see whether treatment is helping. Now, very high risk, consider referral to osteoporosis specialists for assessment and consideration of parenteral treatment like the zoledronic acid, zoledronic acid infusion. If there's a delay, if a delay is anticipated, start oral treatment in the meantime. If not, for referral, if it's for high, in this case, you need to be advising the patient on potential side effects of bisphosphonates like jaw osteonecrosis, thinning of the bones of the jaw. They could have dental problems, they could have esophagitis, so they need to take a tablet in the morning, sitting upright for 30 minutes, and use a full glass of full glass of water, to just reduce the risk of esophagitis. And then obviously, but they were taking a long time, they need to be on proton pump inhibitor, H2 receptor blocker to protect the stomach. So you need to tell them about those things. Okay, so we'll continue. Let's take a break.